Thank everyone for joining this evening. I'm Meena Moran. I'm the chief of Yale Breast Radiation Oncology, and with me is Dr. Haykal, who is the chief of reconstructive surgery. And we are both here this evening to go over some of the relevant San Antonio abstracts that were presented on local regional management. So I'll get started. We have a pretty full agenda. Um, oh, okay, so I have no conflicts, but I am the vice chair of the NCCN breast panel, and as such, I lead the local regional section. So it was difficult this year to actually pick the abstracts for me because there were a lot of really good abstracts. And so I wound up picking 4 that I think are the most clinically relevant for local regional management. And hopefully I'll be able to provide you with some new data, as well as the background and context and the applicability of these data so that they may be useful in your current practices. So abstract 1 is about de-escalation of local regional treatment in older women with small ER-positive tumors following breast-conserving surgery with either endocrine therapy or radiation therapy. So you are all probably aware and know of older women who are low-risk ER-positive patients that are given the option after breast-conserving surgery to omit radiation. And this is primarily based on 2 large studies that were done that established that radiation can be safely omitted in women that are 65 or older with small node-negative tumors that are ER positive, so long as they're willing to commit to 5 years of endocrine therapy. And the omission of radiation based on these trials was shown not to affect survival, not to affect disease-free survival or distant metastasis rates. However, local regional relapse rates, although relatively low, are significantly higher when radiation is omitted, about 1 to 2% at 10 years versus 10% at 10 years, which is 5 to 10 times the magnitude when radiation is omitted. So just to give you a background, the goal of these trials was to try to identify a cohort of elderly low-risk patients in whom radiation could be safely omitted. Why was that? Well, because at the time, 15, 20 years ago, when these trials were designed, radiation was considered extremely toxic for breast cancer patients. The traditional breast cancer courses took 5 to 7 weeks, and they caused acute and long-term toxicity that was significant. So the contemporary radiation therapy advances that we have made have really evolved, and now our radiation is much more precise. We routinely spare the heart, the lung, and even the skin. It's tailored to the individual patient's anatomy using 3-dimensional delivery and treatment planning techniques. And we deliver shorter, more accelerated courses of radiation, with the vast majority of patients getting between 3 and 4 weeks of treatment, and some patients even being allowed to have 5 fractions. So this ultimately has resulted in the perception that breast radiation is better tolerated and less burdensome than it was 2 decades ago. So the question has become, for these older, low-risk patients, can they do an abbreviated course of radiation instead of 5 years of endocrine therapy? And we all know that there are many issues with compliance, adherence, and side effects associated with endocrine therapy. However, there's no prospective data comparing the single modality of endocrine therapy versus radiation. And certainly there's no quality of life measures for radiation therapy versus endocrine therapy. So this is what this abstract and this trial looked at. This is my colleague and friend, Ikro Miatini from Florence, and this was a multi-center study looking at women over the age of 70 with these low-risk features. They were randomized to postoperative radiation therapy or postoperative endocrine therapy. And the study design was that they had to be 70 or older after breast conserving surgery with or without a sentinel node biopsy. They had to have tumors that were 2 centimeters or less, node negative. ERPR had to be greater than 10%, HER2 negative, and they looked at Ki67 being less than 20%. The study is still ongoing and they're still accruing patients. And at the time of this oral presentation, they had 900 patients that were accrued. However, the planned interim analysis was at 2 years. And so they interim analysis was for when they had 152 patients that were enrolled that met the 2-year quality of life follow-up. And the primary endpoint of the study was actually quality of life of endocrine therapy versus the radiation, with the secondary primary endpoint being that they had to be non-inferior to each other in terms of outcomes in local relapse. So here are the patient characteristics. They had a little over 200 patients at the 2-year follow-up. 85% of these patients in the radiation group opted for partial breast radiation. About 2/3 of the cohort were between the ages of 70 and 80. And when looking at the G8 score, which is a screening tool that's used to assess the health status of older patients, they categorized their patients into G8 scores of less than 14, which is a relatively lower health status, and that was about 40% of their cohort. And then they looked at the G8 scores that were greater than 14, which was about 60% of their cohort, so those that had better health status. And the reason that this measure is important is because when stratifying these patients, it allows for ensuring that the arms are balanced and being able to discern whether or not the comorbidities could potentially confound these quality of life measures. So here are the patient characteristics. The protocol required no ink on tumor, but as you can see here, the patients 80% had margins that were greater than 2 millimeters, so they were widely negative. As far as grade, inclusion criteria allowed for patients to have tumors that were of any grade if the tumor was less than 1 centimeter, and only for grade 1 or 2 if the tumor was between 1 and 2 centimeters. But in fact, as you can see, the patients that were analyzed here, there were no grade 3 tumors. All of the tumors were either grade 1 or grade 2. The first thing that they looked at was the EORTC quality of life questionnaire, the 30-item module, or the C30 as we call it, which assesses the various dimensions of health-related quality of life. And it has 2 parts, the functional and the symptom scales. So as you can see here, over the entire 24-month period, the symptoms for radiation therapy were significantly less, and they deviated less from baseline than with the endocrine therapy, which is in red. And then they looked to see if these differences in the C30 functional and symptom scores were being confounded by adjusting for the age and also adjusting for that G8 or general health score. And you can see that despite correcting for age and for comorbidities, that these differences in radiation therapy versus endocrine therapy remain statistically significant, suggesting that patients that take the endocrine therapy feel worse, irrespective of age or comorbidities. Then looking at the various components of the functional part of the C30, with, again, 0 being the baseline, you can see that across the physical, the role, the emotional, the cognitive, the social functioning, clearly the blue bars, which is the radiation, are closer to 0 and deviate less than the red bars, which was the endocrine therapy, suggesting better tolerability with radiation compared to endocrine therapy for most functional domains. In the symptom scale portion of the C30, which assessed, again, all the symptoms that are listed below, you can see that radiation did better in many of these and remained closer to 0 at baseline than the endocrine therapy. Next, they conducted the functional portion of the B45 questionnaire, which is a 9 multi-item scale that assesses body image and sexual functioning, breast satisfaction, systemic therapy effects, and any symptoms related to the arm, the breast, and mucosa, as well as general endocrine function. And here, there were no statistically significant differences between the radiation therapy or the endocrine therapy arms. Next, in the symptoms portion of the B45 questionnaire, you can see that some, but not all, of the parameters were significantly worse for endocrine therapy, namely the systemic therapy-related effects, the skin-related effects, and the endocrine and sexual symptom scales were less changed with radiation than with endocrine therapy. These are the 24-month outcomes. As you can see, the ipsilateral breast tumor recurrence and local regional relapses were 0 in both arms. There were very few contralateral breast cancers, and there were some deaths, as we would expect in this age group. However, none of them were breast cancer-related deaths. So I apologize for this busy slide, but this is assessing the adverse effects. The radiation group exhibited a notably lower treatment-related adverse effect score, 67%, compared with endocrine therapy, it was 85%. However, the overall rate of serious adverse effects was very low and similar between both groups, suggesting that neither treatment had a disproportionately high risk of severe complications. And an important finding was that despite, oops, what's happening here? Despite the, sorry, something's not working. Despite the fact that these patients were on protocol, 22% of these patients required switching endocrine therapy by 2 years, and 12.4% actually discontinued their endocrine therapy. So it'll be very interesting to see what happens with these patients in the long terms in terms of local regional relapse. So in conclusion, the trial showed that the quality of life for radiation therapy was better than endocrine therapy at 24 months in this small subset of their patients on the Europa trial. It did not trigger any stopping rules for local regional relapse, and it's ongoing, so it will have a lot more patients that it'll be reporting on. But currently, I think this is applicable to our practice because patients ask about this question all the time. And I think it emphasizes the need for having in-depth discussions with the patient that incorporate the patient's preferences, their goals of treatment, and also their life priorities when making these decisions and recommendations for our treatment. So this is the actual paper, which was simultaneously published with the oral presentation during San Antonio, for those of you that are interested in reading it. The next abstract is low-risk DCIS. What are the actual benefits of doing endocrine therapy? So similarly to the invasive cancers, we've been trying for many, many years to try to identify low-risk DCIS patients in whom radiation therapy can be omitted because radiation was considered so toxic. So these are 2 studies that I think you need to be familiar with. One is the ECOG 5194. This was a single-arm prospective study. It had 2 cohorts. One was the low-risk cohort, which was low to intermediate grade tumors, less than 2.5 centimeters, and the second group was high-grade tumors, less than 1 centimeter. And they prospectively followed these patients without radiation therapy. They reported 5-year and 7-year outcomes, and they concluded at 7 years that it might be reasonable to observe cohort 1, but clearly cohort 2 with grade 3 disease should not have radiation omitted. However, they then reported their 12-year outcomes. And as you can see here, at this point, the authors concluded that even for group 1, which was the low-risk group, the DCIS recurrence rates continue to rise over this 12 years. And that it emphasized the need to, again, have informed decision-making with the patient, and particularly take into account things like their longevity, because for a patient that's going to be living for 30 or 40 years, this local relapse rate is going to continue to go up over time. The other important study is the RTOG 9804, very similarly looked at low-risk patients, less than 2.5 centimeters with pure DCIS and negative margins, and randomized these patients to radiation versus no radiation. And they reported 7 and 15-year outcomes. And what was very interesting was it was designed to have nearly 2,000 patients enrolled. They had to actually stop the accrual because it was so poorly accrued onto. They only had 600 patients. Despite not having the power to show any significant differences, you can see here at their 15-year follow-up, the risk of local regional relapse was 15% without radiation versus 7% with radiation. So really highlighting the effects of radiation therapy. So this particular abstract at San Antonio last year looked at a combination of these two studies that I just discussed, the RTOG 9804 and the ECOG study, and tried to identify whether or not the patients who got tamoxifen, if it actually made a difference in these patients. And so important to remember that the use of tamoxifen in both of these trials was optional. So not every patient got tamoxifen or was required to take it, but they did track whether or not the patients took it. And so what they ultimately compared, so all these patients had no radiation. They then compared the ones who took tamoxifen versus didn't take tamoxifen to see what the differences were in the outcomes. Now, as you can see here in the prospective 9804, about 66% took tamoxifen, whereas 30% in the ECOG trial took tamoxifen. Combined was about just under 50% that actually took tamoxifen. When you look at patient characteristics, the median age was about 60 years. So these were older postmenopausal patients, and the cohorts were balanced in terms of age and menopausal status for those who took and didn't take tamoxifen. And as you can see here, the majority of patients had widely negative margins. Less than 20% of this cohort who had radiation omitted had tumors that were greater than 1 centimeter in size. So these were relatively small tumors. However, there was a statistically significant difference in those who took tamoxifen versus that didn't across these arms. However, there's really no rhyme or reason as to why some sizes or margin widths or grades took them versus didn't take them. Then they looked at the outcomes. And as you can see here, for ipsilateral breast tumor recurrence stratified by whether or not they took tamoxifen, you can see that the 15-year local relapse rates was 19% versus 11%, which was highly statistically significant. When they broke this down by invasive recurrences versus DCIS recurrences, you can see that the reduction in invasive recurrences was statistically significant. However, the DCIS recurrences was not significantly reduced with the use of tamoxifen. Interestingly, there was no difference in the contralateral breast cancers with the use of tamoxifen at 15 years, as we would expect, which is curious. And then on multivariate analysis, looking at ipsilateral breast recurrent events, both the absence of tamoxifen use and the larger DCIS size were statistically significant in their association with the higher risk of recurrence. Furthermore, on multivariate analysis, the trends for tamoxifen and grade 1 tumors remain statistically significant for lowering invasive breast cancer recurrence risk, but this did not appear to be the case for the DCIS recurrences. And here's the forest plots of the subgroups. As you can see here, here's the midline at 1, with the left side favoring tamoxifen and the right side favoring no tamoxifen. And as you can see, the use of tamoxifen did appear to decrease the hazard ratio across many of these subgroups that were analyzed. So in conclusion, this exploratory analysis that combined RTOG 9804 and the ECOG DCIS low risk study suggests that the use of tamoxifen in patients who are not getting radiated does decrease the overall risk of recurrence from 19% to 11%, and the invasive cancer risk from 11% to 5%. However, in situ recurrences and contralateral breast recurrences are not reduced with endocrine therapy. Obviously, there's no survival data for these for this trial, but again, it highlights the complex treatment decisions that need to be made in conjunction with the patient to help guide decisions. And hopefully future studies using molecular profiling will help to better inform radiation and endocrine therapy decisions for DCIS. Next abstract is post-mastectomy radiation therapy needed for all node-positive patients after mastectomy in the contemporary systemic therapy setting. I'll just bring to your attention that back in 2002, the NCCN was the only guideline that actually suggested for patients with 1 to 3 positive nodes that we consider post-mastectomy radiation therapy. And this has persisted over time. It wasn't until 2014 that the Oxford meta-analysis showed that in patients with 1 to 3 positive nodes, that not only were local regional recurrences reduced, but also there was a breast cancer mortality reduction in patients who got post-mastectomy radiation. However, this reduction was 8% at 20 years. And I want you to remember these numbers, 8% at 20 years. Subsequent to that meta-analysis coming out, other guidelines also changed their recommendations to add 1 to 3 positive nodes for PMRT. The ESMO, the St. Gallen, and ASCO all started recommending that post-mastectomy radiation be delivered for patients with 1 to 3 positive nodes with high-risk features. So why does this controversy continue? Well, because those post-mastectomy trials were done a long time ago, and the current practices are so much more advanced. Systemic therapies are so much better, and we know that systemic therapy significantly affects local regional relapses. And there were a lot of criticisms about the axillary management being inadequate. So the question is now, with contemporary systemic therapy, do all of these patients with 1 to 3 positive nodes need PMRT? And so this was the Supremo trial of these patients. There were 1,600 patients accrued on this trial from 2006 to 2013. Patients had T1 or T2 tumors with N1 disease, which was 1 to 3 positive nodes, or they were allowed to have T3N0 or T2N0 if they had grade 3 or LBSI. All patients underwent mastectomy with negative margins, and they underwent axillary clearance, meaning an axillary lymph node dissection, if they had any positive nodes. So both adjuvant and neoadjuvant chemotherapy were permitted. So the study was powered to look at a 7% survival difference at 10 years, which in my opinion is very optimistic, since the survival outcomes with radiation are generally very long-term. And as I just showed you with the Oxford meta-analysis, the benefit was seen to be about 8% at 20 years. So it's not surprising that there were no significant differences. Nevertheless, this is the randomization chest wall radiation versus no chest wall radiation for these patients. These are the patient characteristics. The arms were very well balanced, as you can see here. And here's what the results show. Overall survival, median follow-up was 10 years, no difference between the arms. When you stratified them by node negative versus positive, no difference. There was a modest difference between the arms for reducing chest wall recurrences at 10 years, and it was very small, 2.5% versus 1.1%. However, this was statistically significant with a p-value of 0.04. And you can see the curves diverging when they blow them up here. When stratifying the local recurrences by nodal status, there was no difference in the node negative patients. However, in the node positive patients, there was a significant reduction with a hazard ratio of 0.3 and a p-value of 0.1. And again, the actual number of recurrences, we're waiting on the manuscript to see all of those fine details. There was a suggestion that regional nodes were also affected. There was a modest benefit in reducing regional recurrences. It was reduced from 4.5% to 2.7% with PMRT. Hazard ratio was 0.6, but the p-value just approached statistical significance, but didn't reach it, 0.06. And when analyzing regional nodal status by regional recurrences by nodal status, you'll see that PMRT reduced local regional recurrences only in the node positive patients. Again, hazard ratio of 0.5, p-value of 0.03. Lastly, when looking at the metastasis-free survival and disease-free survival by treatment arm, you can see that these curves essentially overlap. So there was no global difference between them. So here are the take-home points. These are my take-home points because I didn't want to necessarily say that patients with 1 to 3 positive nodes or intermediate risk should not get PMRT. I think this abstract is very important, and it highlights the important contemporary systemic therapy that's been delivered, and that ultimately the bottom line is that patients with 1 to 3 positive nodes should be selectively discussed for PMRT. And not all patients with 1 to 3 positive nodes require post-mastectomy radiation. However, we're going to need to wait for the trial to further refine which patients we can omit it in. And it's really important because the current practices are de-escalating surgical interventions such as axillary dissection. So right now, what's happening is patients who have 1 or 2 positive nodes on sentinel node biopsy, they are, instead of getting an axillary dissection, are then getting PMRT to cover the full axilla. And keep in mind, the Supremo study required full axillary dissection and forbid full axillary radiation therapy. And so not applicable necessarily in this regard to our current practice. It's likely going to be that this is going to be a much more nuanced discussion. I think we're going to have to separate out this 1 to 3 positive nodes and look at absolute numbers, 1 positive node, 2 positive nodes versus 3, and also take into consideration a lot of other factors like patient age, their longevity, their functional status, and other traditional clinical and pathologic features. And there are other ongoing studies that are also looking at this role of PMRT in potentially lower risk patients. And I just highlight this is a Memorial Sloan Kettering criteria for PMRT. We're also hoping to work with Kate Mason, who's been tasked to develop clinical care pathways. We're hoping to be able to, once this manuscript is out, to also stratify our practices and develop some kind of an algorithm for treating patients that will then separate them by the number of nodes involved as opposed to just the N1 population. And then my last abstract, which I'll go quickly because I'm running over already, is do all patients need a sentinel node biopsy for these small luminal A tumors? You're all probably very familiar with and have heard about the SOUND study, which came out in JAMA in 2023. It's randomizing patients who have T1 tumors to sentinel node biopsy versus no sentinel node biopsy. And this is after doing an axillary ultrasound and determining that it is clear of any suspicious axillary nodes. And this SOUND trial has been practice changing because basically all of their endpoints overlapped, suggesting that we don't need to be doing a sentinel node biopsy unless the medical oncologist needs that information to guide systemic therapy decisions. So this is another trial that similarly looked at omitting sentinel lymph node biopsy in early stage disease. This is the SEMA trial. And this trial was very similar to the SOUND study. They looked at sentinel node biopsy versus no sentinel node biopsy in patients with T1 or T2 tumors up to 5 centimeters. And again, clinically node negative. About 95% had no had axillary ultrasound and were clinically node negative based on the ultrasound. So these are the baseline patient characteristics. As you would expect, only 10% were under the age of 50, and the vast majority were hormone receptor positive, HER2 negative. Primary endpoint was the proportion that was alive and disease-free. Again, identical curves that almost superimpose each other. And when you look at the primary endpoints, as far as the other endpoints, they were pretty much all superimposable as well. They were identical. So overall survival, again, did not differ between the two arms. And when you look at the forest plots without sentinel node biopsy versus with sentinel node biopsy, you can see all of these lines for the subsets cross over one, suggesting that there's no difference whether patients have a sentinel node biopsy or not. So in conclusion, the INSEMA trial is an even larger trial, further supporting the SOUND study, demonstrating that sentinel node biopsy can be omitted in patients that are low risk, that are clinically node negative. This de-escalation concept is suitable for patients who are over the age of 50, grade 1 or grade 2, hormone receptor positive, HER2 negative, with tumor sizes up to 2 centimeters, although the INSEMA trial did include patients up to 5 centimeters as well. And also this study was simultaneously published at the time of San Antonio as well. And I thank you for your attention. We'll have questions at the end after Dr. Haykal speaks.
Thank you. Thank you so much, Dr. Moran.
Okay, I'm sharing with you.
Okay, I'm gonna share my slides now, if that's okay.
Go right ahead.
Yeah. Okay. All right. Okay, can you all see my screen? I know it's hard for... Can you see my screen at all, Meena?
No.
Okay, that's weird. Okay, what about now? Can you see that at all?
I'm seeing you.
It looks like I'm sharing from my end. Elisa, can you see anything or?
Yes, I can see it.
You can see, okay, all right, maybe I'm just missing the window here.
No worries. Okay, so I'll be focusing on the breast cancer reconstructive oncology abstracts that were presented. Now, out of over 1,000 abstracts at the San Antonio Breast Cancer Symposium, there's maybe only about 40 that were focusing on reconstructive surgery. So I'll mainly talk about sort of where they fit into the category of what we currently recommend for patients, what we talk to them about, and generally also describe some of the things that we already do and we currently do. So as most of you I'm sure are aware, timing for breast reconstruction is either immediate at the day of mastectomy or any delayed any day following mastectomy. And the types of breast reconstruction are typically divided into two. So either implant-based with tissue expanders or direct to implant, or using your own tissue to create a breast mound. And there are many factors that affect breast reconstruction decision. Some of them are listed here, but they involve a lot of discussion with our patients. So one of the ways that we can reconstruct is also something that we call aesthetic flat closure, which is basically trying to create an aesthetic result following mastectomy, just to give the scars a more appealing look, to prevent any concavity, to prevent what we call excess lateral tissue. So different types of flat closures are done. Oncoplastic reconstruction is basically when we rearrange the tissue after lumpectomy to achieve a better aesthetic result. And when a portion of the breast is basically removed, we reorient some tissue to bring it back together. So there were about 4 abstracts that were related to oncoplastic reconstruction. This is one where 237 patients and 100 received breast conservation therapy and oncoplastic surgery. And what they found is that for breast conservation surgery was associated with a better quality of life compared to mastectomy, and that oncoplastic surgery was associated with a better quality of life with breast conservation surgery. So this is something that we kind of knew, but there's more and more results, and there are more and more studies that really focus on this. So when we look specifically at outcome measurements, so here they're labeling this as therapeutic mammoplasty, which also relates to oncoplastic reconstruction. They found that patients had a long-lasting positive impact on quality of life. They were very satisfied with their breasts, where sexual and psychological well-being was significantly higher in the long term compared to other types of immediate breast reconstruction, which is huge. And there are physical and well-being outcomes were comparable to implant-based reconstruction, but latissimus dorsi flap had worse outcomes than abdominal free flaps. And we'll talk about flaps as well. This is an interesting, quite innovative study, which really looked at tissue engineering in a partial breast reconstruction. So they used a 3D printed patient-specific scaffolds, and they were able to show that it's a viable alternative, and it could be suitable for patients, but they needed longer-term studies. And specifically looking at patient-reported outcomes, we know that oncoplastic breast-conserving surgery allowed about 95% of participants to avoid mastectomy with lower major complications than immediate breast reconstruction and improved patient-reported outcomes. So now I'll move on to some of the studies that were related to implant reconstruction. So implant-based reconstruction can either be one stage direct to implant, or it could be which would eliminate the need for expansion. The breast reconstruction is done in one step. It does, however, lead to a higher revision rate. And other types are tissue expander-based reconstruction, which is really the gold standard. It's a 2-stage technique where we no longer, many of us have now avoid going under the muscle, and we go above the muscle. Some of us will use mesh. I currently have an R01 looking at the difference between alloderm versus no mesh, no alloderm at all. So we're randomizing patients into that trial. This is an example of a patient that has had tissue expanders. So this is what expanders would look like prior to exchange. And typically we talk about some complications for patients such as rupture and leak, capsular contracture, especially in the context of radiation, infections, exposure. These are some examples of what tissue implant-based reconstruction would look like. This is an example of a direct-to-implant reconstruction with a nipple-sparing mastectomy with the incision being in the fold. And this is an example of a post-radiation treatment effects with implants. The advantages of implant-based reconstruction are a quicker procedure, a shorter recovery time. The option is to select the size of reconstruction. We're only operating on one site. However, it could be more than one surgery. There could be animation deformity, infection, and we know that radiation leads to higher contracture rate. And also the types of implants that we use have now changed because some of them can be associated with certain things such as anaplastic large cell lymphoma. So to discuss a few abstracts, there are about 10 abstracts in this area. Some of them are things that we kind of already knew, but just reinforces some of the themes that we discuss with patients when we see them. So in this study, they looked at health-related quality of life, and the impact of postoperative life for procedures in a Japanese population. Women with breast cancer who underwent either breast conservation, surgery, or immediate breast reconstruction had a significantly higher aesthetic breast satisfaction and psychosocial and sexual well-being. We've kind of known that for a long time, but it's nice that we're looking at different patient populations and also internationally. When we look specifically, sorry, when we compare outcomes of immediate with smooth implants with textured and polyurethane surface, we know that the conclusions were that smooth route implants demonstrated reduced risk of complications, capsular contracture, accelerated rehabilitation period, and higher presentation, however, for displacement of smooth implants. So most commonly, a lot of us, at least in the reconstruction world, tend to deviate away from using any textured implants. And if anything, we, due to the risk of anaplastic large cell lymphoma. In this trial, they actually did a non-randomized single institution observation studies using acellular dermal matrix. So this is the cadaveric sling that I talked about. In this case, they used two different types, such as Braxton or Stratus, and they showed that ADMs show an acceptable complication rate and they're safe to use. However, we do need further studies with certain types of meshes. And this is also very interesting to me and very interesting to know, as we've acquired a robot now at Yale for doing microsurgery. But obviously the Da Vinci robot has been around for a long time, and many people have tried doing nipple-sparing mastectomies using the robot. So this group shows that robotic nipple-sparing mastectomy and implant-based immediate breast reconstruction is safe and feasible, at least for early breast cancer, and has a lot of advantages in terms of keeping a uniform flap thickness, the nipple areolar dissection, and obviously ergonomics for the physician. This is a systematic review of 845 patients who underwent pre-pectoral immediate reconstruction. So I talked about now putting the tissue expander or the implant above the muscle. So this again emphasizes that this is safe, it's a viable technique, and the loss rate for the implants is fairly low, about 5.8%. And the complications would be mainly linked to things such as the complementary treatment and the risk factors. This is an interesting study, which is a randomized trial using Mepitel film to mitigate radiation dermatitis in some patients. And what they did show is that it reduces radiation dermatitis in patients undergoing radiation therapy for breast cancer. However, the long-term adverse and chronic adverse events need to be looked at. This is a group from Brazil who looked at what are the predictive factors of breast reconstruction post-mastectomy, and they found that the negative predictive factors included age of over 60, obesity, diabetes, and positive lymph nodes. And this is another study who looked at patients who underwent mastectomy to really explore what are the factors associated with patient-reported aesthetic outcomes. So the importance are age, their cup size, the types of incision that is used is quite important, and any minimally invasive approaches really show promising trends. So as we move towards that, we can likely achieve better aesthetic outcomes. This is another study that looks at the rate of capsular contracture, which can be associated with all implants. And it was interesting because their complication rates were actually quite high at 24%. But there was no association between capsular contracture and type of systemic treatment. Which theoretically we always talk about, radiation leading to higher capsular contracture. So definitely we need to study that a lot more. Again, another study looking at pre-pectoral immediate breast reconstruction, which shows a low complication rates and minimal implant loss, and there's less breast deformity, there's reduced chronic breast pain, making it a suitable technique. This study sorry, I'm just going to run through this. This study looks at specifically what bra cup sizes in patients and offering them things as nipple-sparing mastectomy. Again, we try to avoid nipple-sparing mastectomy in patients, obviously for oncological perspective, but if there is no contraindication to keeping it, then a certain degree of ptosis and breast size becomes important. So here, we know that endoscopic mastectomy is something that was also used. So for patients who have a smaller cup size, this could be a good technique to use. And then I'm just going to run through this a little bit and just show the next one. These are just kind of reinstating a few of some of the things we already talked about. So the next group is autologous breast reconstruction. So the most common flap that we use is a flap from the abdomen. It's called the deep flap. So these are the different areas, however, that we can take the flaps from. We're using our own patient's own tissue to create a breast mount. It avoids all the complications with implants, and it has a pretty nice donor site. A tram flap is rarely used nowadays, as many of us are microsurgical trained, and this is provides the best outcome for patients as it prevents using the muscle and causing abdominal weakness. These are what the little vessels look like. We identify them in the operating room. We disconnect them and we reconnect them in the ribs. We also can use a nerve to bring back sensation or to not fully, and we watch the patients very closely. These are examples of patients who underwent a deep flap reconstruction. And it could be done either immediate or delayed. However, the scars will look different. And the advantages are that most of the reconstruction is done at the time of surgery. We're using patient's own tissue. It's the best substitute for natural looking breast. However, it's a longer procedure and a longer recovery time. So this abstract looked at outcomes after autologous breast reconstruction for patients with triple negative breast cancer and found that there is no significant difference in recurrence or mortality by race after mastectomy and autologous breast reconstruction for patients with triple negative breast cancer. This study looked at the associations with BMI and patient-reported body image satisfaction following immediate autologous breast reconstruction. And what they found is that obese and overweight patients may benefit from additional body image counseling and screening for depression, and making the appropriate referrals may be important for these patients. When we looked specifically at reconstruction using for things like chest wall disease and chest wall recurrence to facilitate breast conservation therapy, they looked at long-term oncological outcomes. They were the first cohort to publish on long-term oncological outcomes for patients who had chest wall recurrence. And this approach, they're saying, can avoid mastectomy for relatively large or multifocal tumors. And then this study looked at to compare the incidence of local recurrence of patients with or without reconstruction. And currently, it shows that there is no evidence, the evidence does not support that the use of things like lipofilling, so that's taking fat from the other part of from the abdomen and filling some areas. It does not support the opinion that the use of lipofilling following mastectomy or conservative surgery is related to any increases in local regional recurrence. And there's quite a few studies actually right now that really show that if you have good radiologists who can follow patients, that lipofilling does not lead to worse outcomes. So what about things like implant plus autologous tissue, such as a latissimus dorsi? So that's basically placing an expander at the type of mastectomy and removing the expander at a later time and replacing it with autologous tissue at a later date. Not always necessarily using an LD muscle, which is a muscle from the back, but also using a free flap from the belly. These are just examples of some of the patients where, this is a post-lumpectomy defect where I used a latissimus dorsi to just bring back some of the tissue. And this is somebody who had latissimus dorsi reconstruction with bilateral implants. And the advantages of this is that it can be used in patients who've had previous radiation who still want implants. It can also be used in patients who are maybe too thin or have had previously had abdominoplasty. And the disadvantage is it has all the risk of implants and all the risk of using your own tissue. Final thing that I want to talk about, which is not necessarily present as one of the abstracts in the San Antonio, is nipple areola tattooing, which is something that is completely elective, that is performed no earlier than 3 months after initial reconstruction, can be done under local anesthetic and sedation, and has a short recovery time. And then tattooing. So there's 2 different ways that we can do it. We can either bunch up some tissue and make it look like there's a nipple and then tattoo the whole thing. Alina is our APRN, who's certified surgical physician assistant and certified in tattoo art. And this is somebody who had actually a 3D tattoo. And this is an example of a 3D tattoo where we don't bunch up any tissue, but we basically make the tattoo look like there's elevation. So this is my talk related to, and we're all happy to answer any questions that you might have, either for Dr. Moran and I. I know, I don't think you can necessarily put your camera on, but please feel free to put your questions in the chat or in the Q&A box.
While we're waiting to see if anyone has any questions, can I ask you a question, Dr.
Of
Haykal?
course.
Can you just talk a little bit more about that 3D nipple tattooing? I haven't seen that. That's very
Yeah.
interesting.
It's really cool. So what
Can you
it
explain
is
what that is and how it works?
sure. Yeah. So basically, the way that you can actually tattoo, which can, depending on the type of shading and the type of ink that you use, it can make it look like there's an elevation. So it actually takes a little bit more time to do than a regular tattoo, but it's about working with the appropriate pigments to really bring that out. So unlike, the sort of the flaps that we do, which is a little bit of origami, where we bunch up some tissue and make it look like there's a nipple elevation, you actually don't need to undergo that procedure. So it actually feels completely flat, but
Wow.
as you look, it has like a 3D look. So it's super
Optical illusion.
exactly.
Wow, that's cool.
Yeah.
Yeah. I don't see any questions. Does anyone have any questions from the audience? Thanks for hanging with us, guys.
There's one right now. It's for you, Dr. Moran. It says,
I've not seen it.
do you see any changes coming in terms of the technology of radiation therapy devices?
Devices. So I'm not sure what is meant by devices. Our linear accelerators, continue to have a lot of advancements in them, and actually across Yale, all of our linear accelerators are being from all the way from Waterford through Greenwich are all being replaced right now. So we're getting the latest technology for them. In terms of, how we deliver it, it's very site specific. So for breast cancer specifically, we have, different types of whole breast radiation. Then depending on what's needed, patients may or may not have their nodes treated. And then we also have the option of partial breast. And we used to do partial breast using it could be done internally by putting in either a device or brachytherapy or some catheters. We have found that actually just using the linear accelerator and doing an external beam technique to a small volume is actually the most well tolerated and has very, very good outcomes in the appropriately selected patients. And so I think all of those advances together have made a big difference. Whether there's a specific thing, I don't know. Proton therapy maybe, which is, very selectively used, not really reimbursed in standard cases. However, there's still a lot of controversy with using proton therapy. So it's still being looked at in studies.
Great. I don't see any other questions.
Okay, well, I think we're just finishing just about on time.